Thank you for inviting me to speak. Pre, during and post the COVID-19 pandemic. And just really emphasise that this therapy is for more than just COVID patients. It has a role in many patients. So these are my approaches, interests, none of which are particularly conflict with us. So you know where I come from. I'm a intensive care specialist from Hawke, Australia, New Zealand, and I'm also the Associate Dean of the University of Otago School of Medicine. At the start of the COVID pandemic, there was concern that some of the therapies we were going to use would be aerosol generated, therefore increase the risk of spread to staff members and other members of the patient population. These two studies, Whittle and Way studies that were conducted, show quite clearly that high flow nasal cannula at 60 litres, which is a fairly well maximum flow, causes very little increase in maximum air solution from a patient. And you can see in both these studies that high flow nasal cannula had a spread of 70 centimetres compared to the lowest, which is an ordinary breathing mask of 10. But compared to a nebulizer, non-invasive ventilation, simple face masks, were proportionally much higher. Therefore, high flow therapy is a safe therapy to be used with COVID. But what about its efficacy? This is a study done in Spain, one of the two large cohort studies that were completed in Spain, looking at the outcomes of patients who received high flow therapy, non-invasive therapy, or conventional CPAP. And you can see here that the survivorship was only about 50% in invasive ventilation. By comparison, those that received high flow therapy had mortality of greater than 75%. So it appeared, at least in this COVID study, to be a survival benefit to use high flow therapy over non-invasive. And CPAP, mask CPAP, came and are very close to the high flow therapy outcomes as well. This is the other study from Spain, Luis Garcia, and they looked at the rate of intubation for patients who received high flow therapy. You can see that those receiving oxygen masks had a much higher rate of intubation than those receiving non-invasive ventilation. But importantly, high flow therapy, the blue line, had a much lower rate overall, less than 73% of patients who received high flow nasal cannula ended up being intubated. So therefore, less demand on the health services using this therapy. Now, many years ago, when the RSN study was conducted, as we moved our ventilation, the tidal volumes were compared of 6 mils to 12 mils per kilogram. If you look at those patients and the first 4 days, those that received 12 mils per kilogram had better oxygenation than those who received 6 mils per kilogram. Clearly showed here the P ratio was higher than 12 mils per kilogram on 1 days 1, 2, and 3, and subsequently they merged together. Based on this, based on oxygenation outcome, you'd think that high tidal volumes were beneficial. The mortality, however, was nearly 40% at 12 mils per kilogram and only 31% in the local. So it was not clear that oxygen parameters as it were useful and didn't correlate necessarily with outcome. We need to think about how do we resist breathing. Well, how do we resist breathing? The plan is to get oxygen and get carbon dioxide out. Getting carbon dioxide is easy. We give them increased FiO2, usually by raising the oxygen flows out of the mask or increasing the oxygen concentration on the ventilator. The second way is to raise the mean alveolar pressure. If you're on a ventilator, this means increasing the tidal volume, increasing the pause time, changing the IE ratio to increase the inspiratory time, or increasing the peak. Increasing peak has 2 mechanisms of action. Firstly, to raise the mean alveolar pressure, increasing oxygenation. But the second effect is that reopens alveoli and prevents the tidal collapse during ventilation, and therefore decreases the shunt factor, allowing better oxygenation of the blood as it passes through the lungs. And the third mechanism is by recruitment, which is a sustained pressure to reopen alveoli and decrease shunt. Getting carbon dioxide, on the other hand, is an important part of ventilation. And one of the ways we do this is by increasing the minute ventilation and reducing the work of breathing. Increasing the minute ventilation involves increasing the respiratory rate, increasing the tidal volume, or decreasing the dead space. And these all will result in either reduced carbon dioxide in the blood or the same amount of carbon dioxide being removed for a lower work of breathing, which is beneficial for the patient. So the definition of sleep apnea is a CO2 is less than 90 mg, and the most common form of respiratory failure, including the one we often hear in COVID, and it's often associated with many of the acute illnesses that we see in the group now. Hypercapnic respiratory failure is characterised by a rise in CO2, usually by definition above 50 milligrams of mercury, and it can be acute or chronic. Patients may or may not be hypoxic, depending on the degree of hypercapnia and the other underlying disease groups. The causes of acute hypoxic respiratory failure are many, and although in the last year or 3 years we've focused largely on COVID-19 as a virus that causes acute hypoxemia, you can look in this list and there are many causes of hypoxic respiratory failure. Simple pneumonia from bacterial or other causes, cardiogenic pulmonary edema, hypersensitive pneumonitis, congenital heart disease, fatty liver syndrome, obesity, can all cause acute hypoxemia. And what we're going to talk about through the slide is that high-flow nasal cannula is a useful therapy on many, if not all, of these. Now, with treating acute respiratory failure, treat the underlying cause. Remembering that oxygen is not a cure, and ventilation is not a cure, although it may be necessary to support the patient and prevent being hypoxic and then suffer the consequences of that hypoxia. It's important that oxygen will not make them better, neither will ventilation, but it will stop them dying in the time it takes for the body to heal itself and the lungs to return to a normal state. We're going to talk now about the supportive treatment that's related. Now, non-invasive techniques are very commonly used to support patients with respiratory failure, and they are very useful, particularly in chronic lung disease, COPD exacerbations, cardiogenic pulmonary edema, sometimes in asthma, and sometimes to support patients in the post-operative phase when they've been extubated already, and sometimes in patients who've been ventilated and extubated. It is extremely useful in patients that have increased work of breathing and have respiratory fatigue, so long as it's implemented before the fatigue is severe. It is, however, in my view, it's not useful in hypoxemia in the longer term. And while non-invasive ventilation may, in the short term, improve oxygenation and therefore may be useful as a bridge to intubation, in the longer term, it will not prevent patients from harm, dying, or requiring ventilation when it is used. Therefore, we should reserve non-invasive techniques for situations where there is an increased work of breathing and the list on the left, and not for situations when hypoxemia is the major issue. Now, how do we deliver oxygen? Traditional oxygen therapies comes in a number of forms. On the left, you can see low-flow nasal prongs, which can be delivered up to 4 to perhaps 6 litres to give a small amount of oxygen. A simple face mask, which delivers oxygen, a bit like the nasal prongs. Then there's the humidified high-flow mask, which many of us have used for some years, which delivers high flows of oxygen to the patient, and it's usually humidified. There are the Venturi-style masks, which by using a venturi valve allow the entrainment of air given a known concentration at high flows of oxygen so that the patient can receive a known concentration. And there's the rebreather mask, which you can see here, which is an efficient way to deliver oxygen because during inhalation, the patient breathes the contents of the bag, and as they breathe out, the bag fills with fresh oxygen during the expiratory phase, which is available to the patient when they breathe in again. So oxygen therapy can be divided then into variable performance devices and fixed performance devices. This is an example of a variable performance device, a simple face mask, a Medi mask or Hudson mask. And the effect here is that at the beginning of the respiratory cycle, when the patient is breathing gently, say at under 6 litres per minute, just about all the gas they're breathing in will be the gas from the mask. In other words, 6 litres of oxygen. And so they will receive 100% oxygen. Later in the respiratory cycle, when the respiratory flow rate has increased to here 30 litres per minute, there is a change. There's still 6 litres of oxygen being delivered, but there is now patients entraining 24 litres of air, giving an overall oxygen concentration of 37% oxygen. Now that's fine because the patient's stable, but as the patient starts to breathe harder and faster, the inspired gas flows will increase as the inspiratory flows to the patient will increase, and therefore more and more air will be entrained. So as the patient becomes unwell, the oxygen concentration then being delivered will be lower and lower. A constant performance device is one of them that's shown here, just with a face mask, but it gives a high flow of gas, which is at a known concentration. In this case, there's a blender that's delivering 100% oxygen at 15 litres and air at 15 litres, giving an overall concentration of oxygen. So long as that flow matches the peak inspiratory flow of the patient at 30 litres, the gas that's being breathed in will be 60%. If we were tuning the oxygen concentration up, so long as we maintain the flows, the patient will receive more oxygen. And if we turn the oxygen concentration down, they receive oxygen at that concentration. Now I want to talk for a minute about high-flow nasal therapy with Optiflow. This system integrates heated, humidified blended gases which are delivered via nasal cannula. It involves 3 components. There needs to be a flow device, a warm water bath humidifier, and a set of nasal cannula. And all 3 components of this are important. It can deliver gas flows from 3 to 60 litres per minute, and it can deliver oxygen concentration from 21 to 100% oxygen. It's dependent on the use of these appropriate nasal cannula and a single limb heated circuit. I'll talk more about this in a minute, but it's important that all 3 components of this are used, because without the humidifier, the patient's nasal mucosa will come to harm. Without the special nasal cannula, there's a chance of doing damage to the patient. Without the flow device, we simply can't deliver the flows to match the inspiratory flows that the patient needs. Now, this is one of the things that high flow does. It's able to give a constant oxygen delivery. In other words, it's a constant performance device. This is a graph showing the breathing profile using standard nasal cannula at 4 litres per minute, which allows entrainment of air. And you can see, as I've demonstrated, the first start of inspiration, there's 100% oxygen being delivered. But as the flows increase, in this case to 35 litres, more and more air is entrained. And the real oxygen concentration is a mixture of the FI2 being inspired from the circle, which is 100%, and the 21% of the air. So the real FI2 will be lower. If we were to use a high flow device designed to deliver a known concentration of gas, all the gas flow that goes into the patient comes from the circuit, and therefore there's a known and constant amount of oxygen being delivered to the patient. Now, we've talked about the use of high flow, and I've shown you the data, some of the data suggesting it's useful in COVID. However, there are many non-COVID clinical indications, which we have data for that suggest that this is a benefit to patients. Hypoxic respiratory failure, heart failure or pulmonary edema, post-extubation, again, chronic lung disease with COPD exacerbations and hypercapnia, it's used in chest trauma, in comfort, during rapid sequence induction, and as a way of oxygenating patients during procedural things, including bronchoscopy. The secret to this are these proprietary high-flow nasal cannula, which are made of silicone, fit nicely in the nose, cause little or no excoriation, and are comfortable for patients to wear. Not only does it give a constant supply of flow nasal cannula, it is not just the oxygen. This is some data from a study by Rachel Park at Auckland Hospital, and she looked at a number of patients that were receiving oxygen via face mask in the post-operative phase. She placed a 10 French cannula into their noses and measured the pressures at the back of their nasopharyngeal area and measured the pressure. She then, in a crossover study, looked at those receiving Optiflow and when they were receiving Optiflow and when they were receiving face mask. What you can see here in this data is simply from one patient, and the pressures seen in the back of the throat when using the red line, a simple face mask, the pressures are essentially close to zero. When high flow, Optiflow at 35 litres was used, there's an average pressure of about 2.5 centimetres of water throughout the respiratory cycle. In other words, there's a degree of positive airway pressure induced to the patient. But how does this help? I want to talk now about a case. This is a 28-year-old female who was 6 weeks postpartum with no past history, although she had been noted to be hypertensive in pregnancy with one syncopal collapse earlier on. She was at home, she suffered a cardiac arrest, she received CPR by her family and then the ambulance staff, and she had a return of spontaneous circulation after 30 minutes. On admission, she had a number of investigations done. She found to have no PE, no intracranial bleed or cerebral infarction, but she was noted to have global hyperkinesis of the heart. It's unclear whether it predated the arrest or simply a result of her cardiac arrest. She had poor peripheral perfusion and she had moderate pulmonary aspiration. This is her on day 1 post-cardiac arrest in the ICU. She was ventilated and sedated for 36 hours. Thermia therapy, which is what we normally do, kept her temperature under 36 degrees for 36 hours. The sedation was stopped at the end of that time. She was rousing, but she was agitated, very tube intolerant, and minimal secretions. Every time we sedated her, she became hypotensive. We didn't sedate her, she became agitated. So it was decided to extubate her, but not just extubate her to a mask, but to extubate her to high flow nasal cannula. You can see here, she was put on high flow immediately after she was extubated. So how would high flow nasal cannula help this patient? Well, first of all, we'll oxygenate her, and that's important. But the presence of a positive pressure reduces the shunt by recruiting partially collapsed alveoli. And with her aspiration pneumonitis and the pulmonary edema she was likely to have from her hyperkinetic heart, it's thought that a bit of CPAP will be useful. It also opens up those collapsed alveoli and prevents further tidal collapse, so therefore prevents the ongoing atelectasis that can occur in post-extubation patients. The second thing that positive pressure can do, it can reduce the work of breathing of the patient. Normally, when we're breathing, we're working in this zone here, where it takes a moderate amount of pressure to induce a volume change. In other words, a moderate amount of work to move the tidal volume in and out. If we apply a positive pressure to the patient, what happens is we move up this sigmoid curve to a point when a small pressure change causes quite a large volume change and therefore reduces the work of breathing done by the patient. The positive pressure in the system can cause the lungs to move to a more compliant zone, and therefore there's less work of breathing required to move the minute ventilation required to keep the patient comfortable. A third effect of positive pressure on the lungs is that positive pressure causes a change in afterload. Now, afterload is a difficult concept and we often don't talk about it because it's difficult, but the afterload is the strain seen by the heart as it tries to empty. So raised intrathoracic pressure reduces afterload. It does this because using Laplace's law, seen here, is the tension seen by the heart is equal to the transmural pressure times the radius of the ventricle divided by twice the thickness of the ventricular wall. And normally we're talking about the intracardiac pressure, but with ventilation, there's an increase in the pleural pressure, and therefore it decreases the transmural pressure without changing the intracardiac pressure, and therefore it decreases the afterload. So raised intrathoracic pressure results in decreased left ventricular transmural pressure, decreased afterload, making it easier for this globally hypokinetic heart to beat. So that's the first case. The second case I want to talk about was one with a lady with chest injury. Here she is. She was a tourist in Hawke's Bay and she suffered a road crash in which her partner was killed and quite a significant chest injury. Now, we've used high-flow nasopneumonia for many years in chest injuries with the proviso that the patient doesn't have an open pneumothorax or an undrained pneumothorax, and it seems to be of some benefit. This is some data from not trauma patients, but from patients with bronchiectasis. And what was done is they were given high-flow nasal therapy for 7 days. Prior to and after the high flow was used, they were given technetium-99 labeled tracer particles, and they looked at the clearance of those particles out of the lungs. You can see here it's quite clear that pre-treatment, the clearance was on the open dashes, and then after treatment with high flow for 7 days, there's an increased clearance through the bronchomucociliary tree of the technetium particles. Now, it's not the same disease process, but this clearance, increased clearance, may be useful for patients who have chest injury where they get mucosal damage and increased secretions and an inability to clear them out of the system. So the average area of the curve was lower and therefore they increased the clearance. So that's the second effect. You may be able to make the cilia work better. A third effect, after oxygen and increased clearance, is a reduction in the dead space. Normally, when we breathe in, gas goes into our mouth and in through our nose and out through our nose and out through our mouth. If we give a high flow of gas going in, this flushes out the upper area of the nose and comes out through the mouth. So now there's a unidirectional flow going in our nose and coming out through our mouth, which means the dead space is now starting way down at the base here. This upper area of our airway is no longer full of CO2-laden gas when we breathe in. It is clear of that. And we have a bidirectional pathway, breathing in through the nose and breathing out through the mouth. This reduction in dead space means that the effective tidal volume can be smaller, which means the work of breathing done by the patient can be less. For the same minute ventilation, the patient gets better gas clearance. There are some studies showing this is complex to show, but we just believe that the blue area shows CO2-laden gas, and that on controls there was some CO2-laden gas in the upper airway. When they put on high flow, this was reduced, as I showed in the diagram on the right. You can see that the The dead space, the CO2-laden gas, only starts at the top of the trachea. High-flow nasal cannula are very comfortable, far more comfortable than a non-invasive mask that may occlude the patient's face and eyes. There's lots of evidence now that this is more comfortable for patients. So for no other reason other than it is just more comfortable and patients will tolerate it well, it is useful. So they provide improved comfort and allows greater tolerance compared to oxygen delivered by face masks. And therefore, because it's better tolerated, is likely to have a higher compliance than other systems. It is certainly comfortable. This lady here was admitted post-operatively to our unit. She was a 75-year-old with severe rheumatoid arthritis, bowel obstruction from a tumour, and had very limited neck movement. She was a very difficult intubation and done fibre optically in theatre, and she was found to have severe restrictive and obstructive lung disease. She was moved post-operatively into the ICU, where we elected to extubate her to Optiflow. You see her here comfortable on the high flow device. You can also see in her upper nose the scarring that came from the previous use of non-invasive ventilation in ED and on the ward, and she refused ever to have non-invasive again. She said she wouldn't tolerate that again. It was quite comfortable with the high flow nasal cannula. Now, just to go back to the start really and talk about the indications. High flow nasal cannula, I believe, are really indicated for acute hypoxic respiratory failure in all settings. It's something we should use on every patient prior to considering intubation, unless they require intubation for other reasons. In this study, the Ferrari study done by Jean-Pierre Fratt and his colleagues in France, and it looked at high flow oxygen in patients with acute hypoxic respiratory failure, the very group we've dealt with during COVID, but an important group of non-COVID patients. Now, this is published in 2015, so it didn't include anyone with COVID, but the lessons learned here apply. The study had three arms: those receiving high flow nasal cannula, where they received about 50 litres per minute of high flow, standard oxygen, or non-invasive ventilation receiving a pressure support of about 8. So there were three comparative studies. There were about 100 people in each group that were eligible for randomisation, and about 310 were included in the final analysis. The characteristics of each group were the same as far as age, sex, and demographics, including admitting diagnosis and arterial blood gases and CO2 on admission. The study was completed and published in the middle of 2015, and although it was a study of the primary outcome was to show the rate of intubation, it had some other interesting findings. So what was looking for the cumulative incident of intubation on patients, comparing the three groups. And you can see there on the top the incidence of intubation, a trend towards more intubation in the non-invasive group compared to high flow, and standard oxygen fell somewhere in between. Now, this didn't quite reach statistical significance, but if you look at the patients with severe hypoxic with ratios of less than 200, it did become highly statistically significant with an intubation rate of about 0.3 with the high flow and about just under 60% for non-invasive ventilation, nearly double. Standard oxygen again fell in between, but there was no difference between non-invasive ventilation and standard oxygen. What was surprising and unexpected, but really important, was the mortality figures from the study. This was a secondary outcome, but an important finding that the mortality for non-invasive ventilation was much higher than those for high flow oxygen. In fact, over double. And this was statistically significant. So non-invasive ventilation mortality was nearly 30%, while it was under 15% for high flow oxygen. You can see the graph there, quite important. So the use of high flow oxygen seemed to reduce intubation rates in the very sick group, but overall seems to reduce the mortality of patients receiving high flow therapy. The lower mortality in the high flow group, the cumulative effect of lower intubation rate, and also lower mortality in the intubated patients, it was throughout the whole study. The highest mortality in the non-invasive group, and this was associated with high tidal volumes and riskability. So the groups that seemed to do very badly were those that received non-invasive ventilation and received high tidal volumes when they looked. There's a significance in favour of high flow oxygen on 90-day mortality in the study, and this is a really important finding. So we found this, I've just put the slide in again to show you this is the same finding we had with COVID, that high flow oxygen therapy had a lower rate of intubation, and the rate of intubation was higher in the non-invasive group and oxygen group. And this was consistent with the findings in the hypoxic group. This is a study by Stefan looking at high flow nasal oxygen and non-invasive ventilation in hypoxic patients after cardiothoracic study. Again, a randomized controlled study, the PIPOP study, and they looked at about 800 patients who had screened for inclusion at post-operative ICU patients. So slightly different from the acute hypoxemia. These are post-operative patients. Again, no differences between the groups as far as inclusion criteria. They were randomized. They received BiPAP or high flow nasal oxygen therapy. So two non-invasive forms of support, and you can see there was no difference in their outcome. So this study, although it didn't show a benefit, shows that the use of BiPAP and high flow nasal therapy in the post-operative groups, there was no difference in outcome. In other words, there was no worse outcome in the high flow therapy group. It showed that BiPAP showed us no additional benefit as far as could be shown by the study in its use. And BiPAP, of course, is more complex, required more intervention, and perhaps was more uncomfortable for patients. There were some differences in the study where the PF ratio was slightly higher in the BiPAP group compared to the high flow nasal oxygen group, although the respiratory rates were unchanged. The overall outcome of the study, there's no difference in dyspnea, comfort, ICU and hospital length of stay, in the ICU mortality, or in complications such as pneumonia, pneumothorax. BiPAP, however, because it used the face masks, was prone to more complications such as skin breakdown. The overall finding from this is high flow nasal cannula is not inferior to non-invasive ventilation when used in the post-operative setting. We do need to be careful, though, with the use of high flow nasal cannula. It is not a panacea, and there may be a problem with patients are simply ignored. This is a Korean study, and it's a retrospective observational study of the patients who underwent intubation after failure of high flow nasal cannula. The early failure and late failure, the numbers are much greater in early failure, and they did a propensity matching analysis of 37 per group. And what was found was that the overall ICU mortality was higher in the patient's high flow. So early high flow failure had better outcomes and ICU mortality, intubation success, ventilator free. If you had late failure, mortality was much higher. Another study, completely different usage here of high flow and to prevent desaturation during tracheal intubation in intensive care patients. Now, we're obviously concerned with patients getting hypoxic respiratory failure and they require intubation. And the standard way of doing this is a non-rebreathing reservoir face mask or ambu bag sometimes, or high flow nasal cannula. And in this comparative study, they looked at the difference in hypoxemia. Most patients, the saturations did not fall. A large number of them, it remained at saturations of 100. But in the small number that did, the saturation could fall quite rapidly. And the lowest, when saturation is less than 80, In the high flow were only one patient out of the 50, but in the non-rebreathing bag, reservoir bag, there were 7. So significantly more saturations of less than 80 during ventilation. The lowest sats were 94 in the breathing group, and in the high flow group, 100. So that probably isn't clinically significant, but the number who managed to get severely hypoxemic was much greater. The last thing, we talked about comfort, and at the end of life, when patients are in respiratory distress, it's nice that the treatments that we give them are comfortable. There's no point in non-invasively ventilating them with a mask strapped to their face, so the final moments is a discomfort and distress. The advantage of high-flow nasal cannula is it is not distressing. And this is a study done by Peters and Gay nearly 10 years ago now, to assess the efficacy of high-flow nasal cannula in do not intubate ICU patients. It's a retrospective study, and they looked at the patient records, and they looked at the need for escalation to the NIV. They started and they titrated the flows of high flow from 35 litres up to about 50 litres. And they looked at the change in saturation and the respiratory rate before and after high flow was administered. The outcome was that the use of high flow was well tolerated, provided acceptable oxygenation without need to escalation in over 80% of patients. They also noted that high flow nasal cannula requires less training than NIV, is more acceptable to hospital staff. Importantly, for many people on high flow, they're able to communicate clearly to their families and other people around them, while with non-invasive modalities, this may be lost. So, go back. Why do we assist breathing? Well, we do it for 2 reasons really: to get oxygen in, to get carbon dioxide out. We get oxygen in by increasing the FiO2 or raising the mean alveolar pressure, by increasing the PEEP, and by recruiting the patient's lungs. We get carbon dioxide out by increasing the minute ventilation, and also we do it to reduce the work of breathing to allow the patient more efficient ventilation practice. All these things highlighted in yellow can be achieved for the use of a high flow nasal cannula. Now I just want to show you this video. And the video really is a demonstration that high flow nasal cannula is more than just delivering oxygen. It delivers positive pressure and flushes out the dead space. By delivering positive pressure, we keep the lungs open and prevent harm coming to the lungs. Now in this video, you can see we've got a diver here with a high flow nasal cannula connected to a high flow system, and we'll see what happens. And you can see now that when he opens his mouth, gas is coming out and not going in because there is positive pressure in his throat. And he's breathing quite successfully under the water. So OptiFlow can overcome about 20 to 30 centimetres of water pressure, and it can deliver this at high flows. The high flow nasal cannula are safe and feasible in acute settings. They improve dyspnea and patient comfort. In the large randomised controls trial, it demonstrated its benefit and clinical outcome better than NIV, and not just with COVID patients. And the studies in COVID seem to support that the same outcomes are achieved by the use of high flow nasal cannula compared to NIV. In hypercapnic respiratory failure, high flow may be as good as NIV, and it is certainly worth a trial of it to see if it achieves more comfort and better ventilation before we embark on invasive, non-invasive ventilation. Patient selection is obviously important, and appropriate monitoring, be able to look at and titrate the therapy up and down, be watched closely is key for success. Importantly, however, the patient comfort increases compliance with the therapy. Thank you very much for your time.